Guys, almost there. Hey, for those of us who are joining us on YouTube, thank you very much and welcome. We're so excited to be here. For those of us who are joining us on Facebook, I see a small technical problem on Facebook. It looks like the Facebook stream is not moving forward the way we had hoped it would. So please join us on YouTube if you want to see us. Oh, there we go. We're all set on Facebook. Fantastic. So welcome to our third edition of Women's Health Weekly. We're absolutely fully excited to be here. We had a great crowd last time, and it was a lot of fun. So we're really looking forward to doing it again. I'd like to welcome my co-host again this week, Dr. Jeanette Davison,
Hi.
who, hello,
Hi. Hi there.
who many of you see as a patient, who is fantastic and really enhances what we do here, both at Maiden Lane Medical and on the show. And I'd also like to welcome longtime friend, respected professor, colleague, expert in sexual health, expert in vulvovaginal disorders, world-renowned guy, Dr. Andrew Goldstein. Say hello to everybody.
Hey everybody, glad to be
Thank,
here.
thank you so much for joining us, Dr. Goldstein. We really appreciate it. And we look forward to an exciting talk. Dr. Davison and I have been working with Dr. Goldstein for a number of years as we work very hard to take care of women with a number of sexual health issues and vulvovaginal disorders. And Dr. Goldstein has been a constant presence in our ability to do that, to offer consultation and to offer advice and sometimes see patients that we were having a difficult time managing, and always manages to make things move forward in the right direction for us. So let's get going. Let's get started. Let's talk about. I told everyone, say, hey, come join us. We're going to talk about your vulva. And what's a cooler topic than that? I don't know. Can anyone think of a cooler topic? Maybe. All right, let's see. So here's my first sort of piece on this, is that we know there's a lot of information out there. We know that you have a lot of potential resources to get that information, but what we want to deliver to you here is information from the experts, and that's why we asked Dr. Goldstein to join us. So let me go right to Dr. Goldstein and ask him the big question on my mind. Um, what's so important, or actually, no, let me take a step back. What is a vulva?
It's pretty simple, Ken. It's basically the external genitalia. When people say they look down there and they see their vagina, well, they really don't. They're actually seeing their vulva. So what people call the lips or the labia, the clitoris, all that is the vulva. And so what you can see, unless you're a gynecologist and look inside, which is really when people talk about the vagina, they're really talking about the vulva.
So So you've got the vulva on the outside and the vagina on the inside. Is
That's
that sort of the right way to think about it?
that's the right way to think about it.
And is there a better way to describe it for women who aren't quite, listen, we're gynecologists, so we look at vulvas and vaginas all the time. It's what we do. We very clearly understand the anatomy. Is there a different way to describe it for women who maybe not aren't quite getting it? Or should I put a picture up?
Picture would be great, but also women should really get to know their own anatomy and their own vulvas. So the best way they can learn is actually take a mirror down there and or even use their cell phone and take a photo. But we would encourage women to do vulvar self-exams. They should, just like they'll do breast exams. They should look at their vulva, know what's normal for them. And see the texture, see the color, and explore their own anatomy.
So that's perfect. That's great. And that seems like a really easy thing to do. Dr. Davison, is that what you're telling your patients to do on a regular basis?
I can't say that I would say that on a regular basis for every routine patient. My practice is a bit of routine, as well as chronic pain, vulvar disease. Certainly, especially the patients who come with a complaint, a lesion, known vulvar disease, pelvic pain, then yes, I encourage them. I actually show them with a mirror in the office, and I know Dr. Goldstein does it as well, so that they know exactly what I'm talking about, including if it's applying medication or monitoring a lesion. So certainly in that subset of patients, maybe I should be, but not always routinely in routine patients. So it's a good PSA, Dr. Goldstein.
So
No, the reason I had to do people, when people, if they start having problems, they got to know what it looked like beforehand.
Right.
People say, well, I never noticed this, or I did it. And so this way they'll know. I'm not saying that this has to be done on a daily basis, but once a month, once every 6 months, just look, know your body, and in case there's a problem, then you have a baseline.
Okay.
So that's great. That's a great segue into the next topic that I want to go to is what exactly are so if you're a female patient and you are familiar with your normal anatomy, that's great. But what am I looking for if I'm a woman who's doing regular vulvar exams? What am I looking for to give me an early warning or an early sign on my vulva that maybe something's not quite there, quite right, or something's just plainly abnormal?
So usually what we're having people look for are texture changes or color changes. If there, or even change in the anatomy. So sometimes the skin will look thicker, or it will look whiter, or there'll be changes in pigment, and that can be either increase in pigment or loss of pigment. Also, maybe part of the labia or the lips are sticking together when they shouldn't, or maybe there are small little tears or little fissures that you can see, and you can feel those things. So you're looking for texture changes, color changes, anatomy changes, tears, fissures, and those are mainly the things you're looking for.
Great. Anything to add to that, Dr. Davison?
No, I would agree with that. And, I think a lot of patients will come with a complaint about what's this, I noticed this. And I do say to them, well, have you looked before? And so that's true. Like it might come up that they have a complaint or a symptom, and then that prompts them to look, but then they never had the baseline. So that is sort of going back to the point of having a baseline is helpful to see if there is one of these changes that we're talking about.
Great.
One of the things I do want to point out is that, one thing that people do focus on a lot of times is how red something is or how red their vulva is. And that changes dramatically depending on how much blood flow goes to the area. So if a woman looks when she's aroused, it's going to look redder, fuller than if she's not aroused. It also changes with hormones as well. So that's a good idea to get a baseline. And again, don't focus so much on red, but you're focusing on more of texture changes and erosions or tears or fissures or anatomy changes.
Great. So one of the things I really wanted to do today, and we have a couple of questions coming in on YouTube Live, but one of the things I wanted to address today was symptoms. And I'm going to venture a guess that you're going to tell me and probably agree with me that there's no one symptom that defines any particular vulvar or vulvovaginal disorder or particular problem, but there may be some particular symptoms which patients have on a particular basis from a time standpoint, from a longevity standpoint, or some particular symptoms that are not going away after X treatment that we really want them to come in to address. So I came up with a bunch of them. Maybe you could come up with some more. So itching, odor, discharge, ulcerations, pain and burning, painful intercourse. That seems like a list of like 90+% of the most common complaints that we are going to see as people who take care of vulvovaginal disorders. So you don't have to take them one by one, but maybe just as sort of if you have kind of these things, you should go see your doctor type of conversation. And I think that would be valuable for people to understand what if, then what do I do?
So I guess first in that list, I think the first thing is that if a woman is experiencing pain with intercourse, I think there's no question that she should go to her physician and try to figure out what the cause is. Painful, intercourse should not be painful, and there are causes, but a trained physician should be able to figure out those causes. Now, you may be surprised, but you're certainly not Dr. Levey or Dr. Davison, but our viewers out there may be surprised that the average gynecologist is really not trained in the evaluation of sexual pain disorders. That's unfortunate. So if the gynecologist you go to doesn't seem to know exactly how to evaluate that, or they just keep treating you for infection after infection after infection, and your pain doesn't go away, it's time to look for a specialist in this area, such as ourselves.
Yeah,
additionally,
sorry, Andy, to cut you off.
Sorry, Dr.
we're having a little audio delay.
Okay. The other thing that's really important is there shouldn't be bleeding with intercourse. That's definitely a red flag, and it should be evaluated, because bleeding with intercourse could either mean that there's a vulvar problem such as tearing or a skin disease, or there's a problems with the cervix. And so bleeding with sex is, again, a very important thing that should never be ignored. Additionally, symptoms of burning and itching that last for more than certainly a week, but should also be evaluated, and should not. And we really discourage the self-diagnosis of both yeast infections and bacterial infections, because really good studies have shown that women are not great at self-diagnosing yeast infection. In fact, if a woman is 100% sure she has the yeast infection, it has been shown that she's only correct 51% of the time, and that's even if she's had prior yeast infections. And even more disturbing is that about a third of the time, even if she does have a yeast infection, she has a concurrent bacterial infection at the same time. So a woman who self-treats for a yeast infection is either incorrectly or insufficiently treating themselves about 66% of the times, or 2/3 of the time. So it's really important, if symptoms persist, such as itching and burning for more than a week, that you really should see a physician for an evaluation.
So that's amazing. So a lot of women are out there diagnosing themselves with yeast infections, and almost half of them are getting it wrong.
More than half are getting it wrong, and again, even a third of the people who got the original diagnosis correct are missing in another infection, which is a bacterial infection.
I'm getting some awesome questions from our YouTube audience, and I'd like to have Dr. Goldstein and Dr. Davison address some of them. It's really exciting. So this is one of my near and dear favorite topics that you talk about, because you know the subject so well. So I'll just read the question verbatim. One YouTube audience member is asking, I know there's a link between the pill and the development of vulvodynia, etc. Can this lead to anterior vaginal wall pain? Could this be an extension of the vulvodynia and linked to the bladder somehow? And I think the question is all about, can birth control pills lead to vulvar pain or painful intercourse?
So the answer is absolutely, and this is one of the areas of research that I've done. Now, I want to preface this by saying the majority of women who take birth control pills do not develop pain, and in fact, birth control pills can help vulvar pain for other reasons. Not vulvar pain, but pelvic pain, such as endometriosis or painful periods. So I don't want to throw out the baby with the bathwater and say that all birth control pills are bad. But if you had pain-free sex and started taking oral contraceptive pills, and at some point in time later develop pain with intercourse, very commonly that is a cause of the pain with sex. Now, the other part of that question was, can that cause other pain? Well, the answer is yes, because when you start having pain with sex, one of the most common things that happen is the pelvic floor muscles tighten up. And once they tighten up, then you can have additional complaints, bladder complaints, pain with bowel movements, bleeding with bowel movements. So one thing can lead to another. The analogy I always give is, if you're driving down the road and you hit a patch of ice and your car goes off into a ditch and it's all smashed up. Well, sometimes it doesn't even matter if that patch of ice is on the road there anymore. Now you have an additional set of problems. So birth control pills can be that patch of ice. They can lead you into a ditch, and they can get your car all smashed up. And often just stopping the birth control pill does not resolve the problem.
And I think that's been a lot of the experience that we've had with patients, and I know there's some good evidence in the literature to support exactly what Dr. Goldstein is saying. Dr. Davison, has that been what you've seen as well?
Yes, absolutely. When I talk to patients about treating some of these symptoms, just as you're describing, we talk about stopping the estrogen-containing birth control, and they sort of say, okay, well, that's all I'll do. And or they say, can I just do the physical therapy, but I want to continue the estrogen-containing birth control? And I say the same thing, usually it's treating both problems. You can't just do one. The other thing is not going to necessarily follow suit. So I've had the same experience, yes.
I have a couple of folks in the YouTube audience asking great questions about vulvodynia. So I was going to save that for sort of the end, but a lot of people are asking about, so I really want to get to it, because this is really one of your areas of expertise. Vulvodynia, so the audience doesn't hear me using a term that they don't understand, really just means pain in the vulva, or pain in the structures of the outside and entrance to your vagina. Which we also call introitodynia, which is another word for the entrance to the vagina, or pain at the entrance to the vagina. So some folks are asking some really great questions in this regard, and I'd like to have Dr. Goldstein address some of them. At sort of its basic level, someone really asked a question about if I don't have, and I know there's a lot of information out there on the internet about surgery in association with vulvodynia, and someone asked the question, if I don't have access to surgery, what are my other treatment options? What are the other things I can do to heal or ameliorate symptoms associated with that? And the person who asked the question said it very well, that neuroproliferative subtype, which we often see where there's a lot of that higher nerve density in the tissue specimens. What can I do from a medical standpoint, it sounds like, to be able to help me with some of that?
So it's a great question. So the first thing I think everyone on the audience has to know is that vulvodynia is really a symptom. It's just sort of saying, again, as you said, Dr. Levey, vulvar pain. But there are many different causes. That's sort of just like saying you have chest pain. If you have chest pain, you want to know if you have a heart attack, or if you broke a rib, or you're having a panic attack. The same thing with vulvodynia or vulvar pain. You want to know the causes. Now, one of the best ways to figure out the causes is a diagnostic algorithm that I've published, but that many people use and have changed. And the way you can get to that diagnostic algorithm is you can go to my website, which is called vulvodynia.com. Vulvodynia.com, and if you go under publications and under vulvodynia, that first publication under vulvodynia is the diagnostic algorithm, so that you and your physician can use this diagnostic algorithm to figure out exactly the cause of your vulvodynia. So that's also that diagnostic algorithm is also in a book called When Sex Hurts that I published. But forget the self-promotion. What I want to tell you about
we love it. I promise you, we love it.
But about a treatment for neuroproliferative vestibulectomy, if you can't get surgery, and we don't necessarily recommend surgery for neuroproliferative vestibulectomy unless we call it congenital, meaning you've always had that. We found that if you have congenital neuroproliferative vestibulectomy, that surgery is by far the best option. However, if you have acquired neuroproliferative vestibulectomy, meaning you've had pain-free intercourse and then you develop too many nerve endings, then we have found a medication called capsaicin to be incredibly effective. Capsaicin is the purified extract from chili peppers. Now, what happens is you put this medicine on the vestibule, which is the entrance of the vagina. It's an incredibly painful experience. But what happens is it causes all the nerve endings to get depleted of the chemical that causes pain. It's sort of like wearing out the battery of the nerve endings. So if you can do this every single day for approximately 3 months, there's a 71% reduction in pain. Which means that on average, that's a 71% reduction, which means that a lot of women are getting 100% relief of pain. And even a lot of people are getting 50% of relief of pain. So it's an incredibly effective and inexpensive treatment. Again, it's not a very pleasant treatment, but an incredibly effective and an inexpensive treatment. And I will tell you, Dr. Levy, that I used to do about 60 to 70 of these surgeries a year, and I'm now doing only about 20 to 25 a year. One of the main reasons is treating the hormonal aspect that the last viewer talked about, and the second reason is using capsaicin.
That's great. So there are medical therapies. We have used capsaicin as well. Dr. Davison and I use another medical therapy quite frequently. Dr. Davison, do you want to talk about that briefly?
In terms of other topicals, I think you're thinking of.
Yeah,
correct?
exactly.
So I would say various specialists probably have their topicals of choice, but there's a variety of topicals that you can compound. A compounded medication is a medication that's made up specially per our sort of instruction. And one that we have used with success is a combination of estrogen, so giving the tissue, especially in patients who are maybe deficient from using a birth control pill, ketoprofen, lidocaine, gabapentin, so a couple of different agents mixed together, some that work on nerve modulation, estrogen that can improve tissue quality that also can be deficient after using birth control pills. So a topical like that. Also in patients who specifically have discomfort due to birth control pills, they're also deficient in testosterone, which I know Dr. Goldstein can chime in more, but super important to give testosterone and estrogen back to those patients via topical. So that's another, specifically for patients who've had a history of birth control pill use, that's definitely something that we see helps a lot.
Great. I have another, along that line, I have another question from a viewer that just came in. Do we recommend oral amitriptyline or gabapentin for unprovoked vulvodynia? I don't know if Dr. Goldstein is nodding his head because he likes it, or he's nodding his head because he's heard the question 1,000 times, but now he's shaking his head, and I'm going to totally agree with him. I was actually going to take that question, and I'll just answer it by saying, yeah, there's no good evidence in the literature that treating systemically or centrally with these oral medications offers any long-term benefit to managing vulvar or introidal type pain. Those medications work great for other types of chronic neuropathic type pain, but for the vulvar type pain, they don't really seem to do much of anything by themselves. But I'm gonna. Do you have something to add to that, Dr. Goldstein? I saw your.
If I can.
Yeah, please do.
Yeah, right. Because so first of all, not only you mentioned there's no good evidence. In fact, there's very good evidence to the contrary, which is that they don't help. So that's number one. So, and these are very large, multi-million-dollar NIH-funded studies. The gold standard, double-blind, placebo-controlled trials by experts have shown that both the tricyclic antidepressants, which amitriptyline, nortriptyline, disipramine are in that category, as well as the gabapentin, do not help vulvar pain. Even more scary, if I use a better word, is that many of these medications include the tricyclic antidepressants, increase the risk of coronary artery disease, as well, or heart attack, as well as Alzheimer's disease. So this is sort of very commonly prescribed by people who are not knowledgeable or not up to date about medicine, and they'll prescribe the tricyclics or gabapentin. And in fact, there is long-term health repercussions to these medications, and they have not been shown in very good studies to be useful. So in fact, I'm an author of Vulvodynia guidelines, and one of the strongest recommendations is not to use these medications.
I'd like to get back to two questions that I think we could answer in brief that came from our YouTube audience about vestibulectomy. The first question is natural birth still possible after a vestibulectomy? Are there any long-term risks? Great question.
So the first question, in fact, I published on this a paper.
I knew you were going to say that, Andy.
Sorry. I mean, if you take the time to do the study. So I've done the study, and it showed that women actually do very well with vaginal delivery after vestibulectomy. In fact, in my patient population, women after surgery, 58% of the women have completely no pain after vestibulectomy, but after vaginal delivery, that number goes up to 93%. So actually, vaginal delivery can get rid of any residual pain after vestibulectomy. In addition, women actually tend to tear less if they've had a vestibulectomy than the average woman who's having a vaginal delivery. And the reason is what tends to tear during a vaginal delivery is the vestibule. And so women who no longer have a vestibule tend to not tear at all. So we strongly encourage women who've had a vestibulectomy to have a vaginal delivery.
Very interesting. Since Dr. Davison and I know you don't, but Dr. Davison and I certainly don't do any obstetrics. So we don't, outside of a research setting, we wouldn't really get to see that clinical outcome. Another YouTube viewer asks, I had a successful vestibulectomy, but some pain remains on the urinary meatus. I think it's urethral meatus she's referring to, which can't be removed, of course, right? So the question from that.
But it can be removed.
And there you go.
We're doing research. We're doing a study in Washington, D.C., where we're taking out the last half an inch of the opening of the urethra. We're working with the urologist. The urologist is Dr. Rachel Rubin, and she was actually trained by another famous vulvar specialist by the name of Dr. Erwin Goldstein, who was no relation but a good friend of mine, and also
sure, we know Erwin.
And so we are. So this is a vexing problem, but it's the same tissue of the opening of the urethra as the vestibule. So we are actually now doing a study to remove this tissue safely, and we believe it's going to be successful.
That's great. Dr. Davison and and Dr. Davison, you could speak to this, seem to have had that experience where we've done our best vestibulectomy for patients with medically refractory vulvodynia and wound up with just what you're describing, or just what this YouTube viewer is describing, is some residual pain at the entrance to or the exit of the urethra. We're not sure other than medically how to manage that. Dr. Davison, have you run into this issue, and what do you typically do?
I have, and I will say that one thing to distinguish, which I've been trained by the best because I'm on with the two people who trained me, but we've shared a few patients. Dr. Goldstein has trained me to do a vestibulectomy. I'm so privileged, and it's very important to remove the Skene's gland ostia, which is super close to the urethra, and so I think it's an important point. Not many of us, not many other physicians do vestibulectomies, and so to make sure that whoever did it, is there any, or even to check our own work, is there any residual tissue where you really medial to the Skene's gland ostia? Is there any role of resecting that little bit of tissue that might be actually the source of the pain, which is probably worthwhile investigating even before the urethral resection, perhaps, if that's the case.
I want to spend. I'm sorry. Go ahead, Andy.
No, just basically, we're just. It is important, and occasionally the Skene's glands openings can regrow a little bit. So again, before contemplating letting anyone else do additional surgery, I'd definitely go to an expert in this situation who really knows how to evaluate these small differences, subtleties in the residual pain.
I want to spend 1 or 2 more minutes on vulvodynia because there were a couple of other issues we want to talk about, and I think a good sort of next topic or piece of discussion to have about vulvodynia, because a lot of people are asking about it, a lot more people than I thought we would have asked about it, so maybe we could even spend a few more minutes on it. But one of the YouTube viewers asked a great question, which is absolutely something to consider whenever someone's presenting with certainly vulvar pain, introital pain, pain with intercourse. The question is, how much do you think anxiety and stress contributes to vulvodynia symptoms for a woman who already has vulvodynia? Good, solid question.
It's an incredibly important question, and something that I've actually researched as well. We actually found that about 40% about 40% of women who have diagnosed with vulvodynia meet the criteria for an anxiety disorder. Now, that is important to realize that that doesn't mean that their pain is because they are anxious. The thing about anxiety is it does two things to increase in pain. First of all, the neurochemicals in the brain that are responsible for anxiety are the exact same neurochemicals in the brain that are responsible for pain.
Right.
So to say that someone is more anxious and therefore they're in more pain, that is by definition true. Because they have the exact same chemicals in the brain that are increased for both pain and anxiety. The second thing that increases pain related to anxiety is that women who are anxious tend to tighten up their muscles. They tend to hold in their stress or their anxiety in their muscles. And what that happens is when the muscles get tight, that causes decrease in blood flow to the area, including the pelvic floor, which causes a buildup of lactic acid in the muscles, as well as causes an increase in inflammation, and therefore will cause an increase in pain. So to say that a woman who is anxious has more pain, that is absolutely true, and it is very important to address the anxiety. But I also want to emphasize, and I really want to emphasize, that that doesn't mean that your pain is in your head and that you're crazy and that the only reason you have pain is because you're anxious.
That's a perfect exclamation point on the issue about anxiety and really any pain, but in our case, anxiety and vulvar pain, because they occur so frequently together. One makes the other worse. But it doesn't mean at all that it exists in your head. And any doctor who tells you that should, you should just potentially consider going to find a new doctor. I think and Dr. Davison. Yeah, that would be a nice way to put it. Dr. Davison and I see this quite frequently and have these conversations on a fairly regular basis about how to properly manage these situations. Because there's so much interest in vulvodynia. I'm gonna get to one more question, which is sort of another interesting question is can tight pelvic floor I'll sort of paraphrase this question. Can tight pelvic floor muscles cause delayed pain after sex, such as 24 hours later? Which is a sort of off the topic of straightforward vulvodynia, moving into some pelvic floor muscle spasm conversations and issues around that. But this will be the last one of those we hit, and then we'll go on to some other stuff.
So I can answer that. Just basically, yes. And what happens is tight pelvic floor muscles, when a muscle is tight, there's decrease in oxygen going, there's decrease in blood flow going to the muscle. In fact, if a muscle has about a 10% increase in muscle tone, then there's a decrease in blood flow of over 50%. And so what happens is if there's decrease in blood flow going to those muscles, then there's decrease in oxygen going to those muscles. That does two things. That causes the muscles to live what we call anaerobically, without oxygen. And the byproduct of anaerobic respiration is lactic acid. So lactic acid builds up in the muscle. And you've all probably heard the expression, feel the burn. And so exactly that's what's going on. It's like your muscles are running a marathon. In addition, lack of oxygen causes a buildup of inflammation. There is what we call a hypoxic inflammatory response. That means just lack of oxygen causes inflammation, just like an infection can cause inflammation. And so in that situation, tight pelvic floor muscles can cause burning all the time, or if those muscles get pressed on, like during intercourse or during orgasm, the muscles contract. So that can release the lactic acid and therefore cause a delayed pain response, but there is pain. There's also.
Oh, sorry. Go ahead, Andy. No, go ahead, Andy.
No, there's also increased blood flow during intercourse, and so the area so the area can swell, and the muscles, if they're tight, what will happen is it actually prevents the blood flow from going out of the vulva, and you're no longer aroused. So that causes delayed swelling after intercourse as well, which can cause discomfort.
I want to add, as we kind of wrap up the vulvodynia topic, a YouTube viewer asked the question, could we offer digital consultations and appointments? And I want it to be clear that We do these Women's Health Weekly telecasts because we really enjoy doing them, and we really enjoy talking to people virtually about all of the things that are important to women's health and getting the right expert medical care when it's needed. But if you're asking the question, I'll tell you yes. Dr. Davison and I believe Dr. Goldstein are both available for digital appointments. Dr. Goldstein on aforementioned vulvodynia.com and Dr. Davison through maidenlanemedical.com. And you can certainly make appointments with both of them. And as we kind of come towards what's close to the end of our time, I want to just hit on some of the other areas of vulvar health that are pretty important, or rather, let's do like two final topics. One is just other vulvar problems. You're an expert in the lichens, lichen sclerosis, lichen planus. Other types of potentially ulcerative disease of the vulva, and then just a brief conversation from Dr. Davison about just general vulvar health and maintaining vulvar health. So I think if we hit those two topics, we'll have come a long way in really offering a nice level of education out there to women. So I'll give Dr. Goldstein just a couple minutes to talk about. I'm sorry, I left you confused. So my point is, let's have Dr. Goldstein talk now about some other vulvar disorders, like just a brief rundown.
One of the things that it's not incredibly common, but it affects about 1.5% of women. So about 1 in 60 to 1 in 70 women are skin diseases of the vulva. The vulva is skin. But there are specific skin diseases that can affect the vulva that typically just go there because of the unique environment of the vulva. The most common of those diseases is something called lichen sclerosis. Lichen means thick and scaly in Greek, and the word sclerosis means scarring in Greek. And this is a skin disorder that it can affect females of all age, from kids 2 to 99. And there's some misinformation out there that this is the disease of menopausal women, but it is not. And what lichen sclerosis can do is it can cause itching, it can cause scarring of the vulva, it can cause pain with intercourse, it can cause the entire distortion of the anatomy and scarring of the anatomy of the vulva. And unfortunately, in about 5% of women who get lichen sclerosis, they can develop cancer if not appropriately treated. So this is one of the reasons that I think women should do vulvar exams just to know what their normal anatomy is, because if they notice changes in their anatomy, such as scarring or texture or color changes, that they go to a physician, and because this can be a possibility.
I think that's great. I think that's one of a really key thing, and I think lichen sclerosis of those is probably the most common. Of the more rare things, we usually wind up sending to see Dr. Goldstein anyway. But thank you for that. Yeah, again, lichen sclerosis would be the thing to look out for. So Dr. Davison, in sort of moving to, provided we don't have any other questions associated with these topics, just kind of moving towards wrapping up and talking to our viewers out there about general vulvar health and just taking care of yourself on a daily basis.
Sure. So to summarize from I guess this session and our prior session, I think one of the take homes from this session just simply is to be familiar with your anatomy and not be afraid to check with the mirror, just to know your baselines, that if you have a symptom or if you notice something different, you'll be able to realize and bring it to the attention of your physician. And going back to last week's session, we talked about how the vulva and the vagina are different, but obviously in close proximity. And a lot of the same precautions that we talked about in our last session in terms of vaginal health apply here. So some of the things, and feel free for both of you to add, but avoiding scented products, detergents, soaps. I know Dr. Goldstein tells his patients to wash their underwear separately, just with water, with warm water, without detergents. I think that's correct. And avoiding sort of irritating products, some things that are even marketed towards women that can be deceptive, such as pH balance and wipes and feminine health, which actually really can throw off things and throw off pH. wearing cotton underwear or no underwear. So a lot of the things that we talked about last week are applicable, because even though these might be different conditions such as lichen sclerosis or vestibular vulvodynia, they can be irritated by the same contacts, the same irritants.
It's great.
I want to. That's a great answer, because I think, you know, one of the most common things that causes these itching and burning symptoms are both irritant and allergic reactions. Women put hundreds of chemicals on their vulvas on a, you know, almost like on a weekly basis. Most soaps have, even Dove, which is supposed to be 99.44% pure, has 18 different things in it. Every toilet paper, every menstrual pad, all of these things all have chemicals, and any one of these chemicals can be an irritant or allergic reaction, cause an irritant or allergic reaction. So, you know, the last thing I always say to people is, you know, trees where they make toilet paper, trees are not white, soft, and fluffy and smell good. The reason they're white, soft, and fluffy and smell good is because there are chemicals in that, and that can cause, and any one of those chemicals can cause an irritant or allergic reaction.
That's awesome, guys. We've had some amazingly insightful questions from our YouTube audience. We really appreciate you guys participating. Absolutely fantastic. Thank you, Dr. Goldstein, very much for your time. Thank you, Dr. Davison, very much for your time in joining us today. Once again, vulvodynia.com for Dr. Goldstein, maidenlanemedical.com for Dr. Davison. Dr. Goldstein has a lot of insightful information on his website about these very topics. We really encourage you to go there. Thanks for joining us on our YouTube channel. Please, please, please subscribe to our YouTube channel. We're going to keep these presentations going every week until the cows come home, and even well past COVID-19 crisis and pandemic. We really love doing this. We've discovered a new wheelhouse for ourselves, and we're fantastically excited to continue to talk about it. Have a great day, everybody. Stay safe. Keep your families safe, and be well.
Take care. Thank you.